Good day and welcome to the ASTHO Use of Telepsychiatry to Improve Access to Care for Rural Populations conference call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Megan Miller. Please go ahead.
Hi everyone, my name is Megan Miller. I'm the Senior Director for Health Integration at the Association of State and Territorial Health Officials, or ASTHO. I'd like to welcome you to today's webinar on the use of telepsychiatry to improve access to care for rural populations, state considerations for incorporating telepsychiatry into behavioral health and primary care integrated systems. ASTHO is committed to supporting state and territorial health officials and their leadership teams within the transforming health system. ASTHO, with support from HRSA, is providing this webinar to facilitate sharing of best practices and lessons learned related to telepsychiatry. This webinar is scheduled for an hour and a half and we'll have time set aside for discussion with participants and to answer your question towards the end of the webinar. In an effort to reduce background noise, your lines will be muted during the presentation and when you're not speaking. If you have a question during this call, you're welcome to post it into the chat box on your screen at any time. These questions will be answered during the Q&A at the end of today's presentation. We'll also open the phone lines during the Q&A session for you to ask additional questions. At the conclusion of this call, you'll be directed to an evaluation survey. Please take a few minutes to complete this survey, as we would appreciate any feedback you have to help inform future ASTHO work. Please note that the slides and recording from today's webinar will be sent to all registered participants in the next few days, and we'll post them on our website. And that link will be provided at the end of the webinar, and I believe it's in the chat box right now. I'd now like to go ahead and introduce today's speakers. First, we have Dr. Jonathan Neufeld. Jonathan Neufeld is the Program Director of the Great Plains Telehealth Resource and Assistance Center, the federally funded technical assistance program housed at the University of Minnesota. The center provides telehealth training and consultation to healthcare providers and programs interested in implementing, evaluating, and enhancing all types of telehealth services in the Great Plains region. Dr. Neufeld has consulted on a wide range of projects related to rural health and telehealth over the past 15 years. He's presented at regional and national conferences and published peer-reviewed articles in the fields of telemedicine, clinical decision support tools, mental health services evaluation, and clinical outcomes. Dr. Neufeld received his PhD in clinical psychology from Ohio University and completed a postdoctoral fellowship in integrated primary care in the Department of Family and Community Medicine at UC Davis Medical Center in Sacramento, California. Our next speaker is Dr. Anna Ratzlaff. She's an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. Dr. Ratzlaff received her MD PhD in 2005 from the University of California, Irvine. She completed a residency training in psychiatry and served as the chief resident at the University of Washington Medical Center. Dr. Ratzlaff currently serves as the director of the UW Integrated Care Training Program, associate director for education for the AIM Center, and works as a psychiatric consultant for the Mental Health Integration Program and trains psychiatric residents at the University of Washington. Her clinical expertise includes primary care consultation and providing mental health care to underserved populations. Dr. Ratzlaff's academic pursuits include developing strategies to provide mental health education to members of integrated care teams and studying the impact of integrated mental health care programs in special populations. And our final speaker is Brian Cooper. For the last 3 years, Brian Cooper has served as a telepsychiatry and rural hospital specialist at the North Carolina Office of Rural Health. His role at the Office of Rural Health has engaged him with the North Carolina Flex program for critical access hospitals and the North Carolina statewide telepsychiatry program. Brian holds a master's in healthcare administration from the University of North Carolina Gillings School of Global Public Health and a basic certificate in quality and safety from the Institution for Healthcare Improvement Open School. I'll now go ahead and turn it over to Dr. Neufeld.
All right, thank you, Megan. And good afternoon, everybody. I hope to quickly go through some background and sort of set some context in place so that Dr. Ratzlaff and Brian can be able to tell you more specifics about the programs that they run and have been operating for a while, and not have to spend so much time on context. I want to start off by saying a little bit about who the Great Plains Telehealth Resource and Assistance Center is in the context in which we operate. And so I'm going to jump right into that. GP Track, we call it GP Track for short, is one of 14 federally funded centers across the country. Each of us is funded by the Health Resources and Services Administration in a little department called the Office for the Advancement of Telehealth. And each of these centers covers a geographic region or a specialty area. We collaborate together quite a bit. And our mandate from HRSA is to provide technical assistance and training to organizations that are looking to implement or evaluate or extend or sustain telehealth programs. And our primary target group are safety net programs, government offices and agencies, organizations that wouldn't normally be in the market for a consulting firm, or that might but couldn't afford one. Our services are all grant funded, so we can provide those kinds of consultations and technical assistance for free to organizations that need them. And the whole goal, of course, is to make services more widely available across the country. There is a national website where you can get to all 14 of them, any of them, through links on the website, and it is at telehealthresourcecenters.org. And that website hosts our national webinar series, as well as links to all of the centers across the country. And feel free, I encourage you also to visit any of those sites. There's a wealth of information on all of those websites. We all collaborate freely and openly. You are not limited geographically to which sites you contact or which sites the websites that you look through. I mean, we share and share alike all across the consortium, so it's a really great resource, and I want to encourage people to check it out. A couple of things that I want to do to start to kind of set a background here and set some boundaries around and definitions of the topics that we're talking about. Telehealth is a huge topic, and it has grown tremendously and will continue to grow for the foreseeable future. And it can be very confusing what exactly we're talking about when we're talking about telehealth. And so rather than try and define it one particular way, what I want to do instead is encourage people to first understand what service exactly you're talking about with, when somebody brings up the topic, and to recognize that we can be talking in multiple domains. There are at least 4 common domains for telehealth. One is hospital and specialty care, and that's primarily what we're going to be talking about today. And this involves, various specialized medical services that are usually available only in urban areas, partly because they're less commonly available. Just take a higher degree of training. There are fewer of the specialists available, so they tend to be concentrated in urban areas. And then the goal of telehealth in this domain is to make those specialty services available through a wider geographic region. There is also a domain, integrated primary care, that has arisen a little more recently, but it's similar to the first, but it's kind of the mirror image. It's the flip side. It's what it looks like, what telehealth looks like from the perspective of a clinic that wants to bring specialty services in and enrich the primary care environment through the use of those specialty services. We also have a whole lot of work being done these days on monitoring, various types of remote patient monitoring, and helping to manage transitions between inpatient and outpatient, and from nursing care to inpatient, nursing care to home, all of those types of transitions, and even just sustaining better health outcomes when patients transition to home and staying at home longer. So there's a whole lot of work being done there. And then, of course, there's probably the newest, but one of the most recently most visible domains, and that's direct-to-consumer care. And that's usually primary care or urgent care. You're avoiding a trip to the doctor, a trip to the ER, a trip to urgent care through directly connecting with a doctor at home. So telehealth can refer to services in any of those domains. And it's important to be clear what we're talking about when we're talking about telehealth, which domain we're in. A couple of prerequisites to talk about telehealth that I want to talk about. First, one is that telemedicine or telehealth, and I use those two terms interchangeably. Some people like to distinguish them. If there is a distinction, for me, it's important to recognize that some services are billable on a per-service basis, and so some speakers will use the term telemedicine for a service that is billable as a service. And then there are a whole range of services that are billable on a different basis, or maybe not even billable at all, and these might include home monitoring services or other types of services that are either billed on a monthly basis or are just provided as a quality of care or to improve outcomes, and then hopefully are sustainable through quality payments or through an alternative payment arrangement of some kind. So that's the kind of distinction a lot of people will make when talking about telemedicine, telehealth. But the point that I'm making here in terms of a conceptual framework is that these various types of services are ways of delivering healthcare, but they are not healthcare services per se. So, for example, if a psychiatrist is providing telepsychiatry services is no different at a functional level from psychiatry service. They're billing the same code, they're providing the same exact thing. The telehealth part, is just the fact that they're not in the same room with the patient. And so the service itself, the way it's evaluated and billed and regulated, is very much almost identical to the service how that would be provided in person. Sometimes I use the analogy of providing care in sunlight versus in artificial light. Some people talk about other analogies like using the drive-through at a bank instead of going in to talk to the teller. You can do many of the same interactions and exchanges. Some maybe you can't just because physically you're not there. But for the most part, the service is the same. Another prerequisite to recognize is that in the regulatory environment at the federal level, there are very few restrictions about what can or can't be done at a distance. For example, one of the only federal laws is around controlled substance prescribing, and it's not really fully fleshed out. There's a mention that some restrictions on controlled substance prescribing for patients the doctor has not seen in person. There's an exemption in the law for telemedicine, but it has remained undefined. Actually, it was supposed to be defined very quickly after the passage of the Ryan-Haight Act, but it was never defined fully. So it's a little unclear what's going on there. But for sort of simplicity, one can just take that Ryan-Haight Act as saying that if a doctor has not already established a relationship with the patient, then they can't prescribe controlled substances to that patient. Now, that's a little bit of an overgeneralization, and I'm not going to go into the details, but that's sort of where the see the patient in person first guideline comes from, as well as other areas as well. So most telemedicine regulations happen at the state level, and they're actually implemented through state licensure laws. So various licensees, whether they're physicians, psychologists, nurse practitioners, whoever, what they can and can't do in telehealth is regulated through licensure. Now, what's more common than regulation is actually what are called conditions of payment, where you maybe can do an awful lot of things in healthcare, but what you can get paid for usually determines what actually gets implemented in a program. And conditions of payment are regulated by the payers. So for Medicare, that would be at a federal level, and conditions of payment for telemedicine and Medicare are standardized across the country, regulated at a federal level. But what Medicaid will pay for is regulated, of course, at a state level. As well as commercial payers, what commercial payers must cover if it's regulated, it would be regulated at a state level. And then, of course, commercial payers will have internal policies, and those could vary all the way down to the actual plan that a patient has, whether or not telemedicine services are covered. Now, most commercial payers don't get into that level of detail. They'll usually have broader, organization-wide or contract family-wide policies around telehealth. But as you can see, that's what determines what is practical to implement in terms of a telehealth service. So it's not what can or can't be done at a regulatory legal level usually, although state licensing boards sometimes will have pretty strict guidelines about that. Many states are actually silent about this. But usually the practical level comes about in terms of what can be paid for. So another sort of prerequisite to recognize, excuse me, or regulatory conventions are that what states will often do is they'll define what telemedicine is or isn't, and so so that the term can be used more effectively in legislation and in regulation. And usually telemedicine is defined, or telehealth is defined as live interactive video. And usually store and forward telemedicine, which is also called asynchronous, so that would be something where, for example, there's an image taken of a skin lesion or of a pathological slide of a cell or something, and then that image is reviewed by a provider at another time and another place, and then they make a recommendation or an evaluation based on the image. And it could also include an audio file or even a video file. Think of a Doppler, a cardiogram of some kind. Any stored data could be reviewed later and evaluated. But usually those services are regulated separately from live interactive video, where you have live video, healthcare provided over live video. Telephone, fax, and email are almost always excluded from the definition, but going down to my second point there, expanded applications of telecommunications in healthcare are changing rapidly. And what we're realizing is that because of a couple of things, population health, the recognition that we can do a lot of small things to help people stay healthier better, it's really stretching the idea of what we do in healthcare. Not everything that we do in healthcare is a billable encounter. And because simpler low-cost options are available, and sometimes they can be, a just-in-time text message or a just-in-time phone call can be as effective as waiting till next week to see the doctor in person, these types of services are being developed more and more extensively in the context of population health because they're effective, even though they don't necessarily match the sort of legacy definition of what is an encounter or what is telemedicine. And then there are also recognitions that seeing the doctor directly and have the doctor prescribe something to you, a specialist prescribe something to you or implement a treatment plan of some kind, is one type of health care. But sometimes when providers are hard to come by, when specialty services aren't available, having one specialized physician or provider train other providers or somehow facilitate work by other providers, what we call a force multiplier, can be a very effective way of making services available in underserved areas. And so there are programs now that are focusing on being force multipliers rather than just making specialized services directly available to patients, through video encounters. So there are both of these things that are being done quite effectively, and you're going to hear some examples that use these types of interventions. Another thing, so I'll just briefly say when you talk about support or payment for services, you end up with a matrix, something like this, that says here's what Medicare will pay for, what types of providers, what types of services, other things that may not qualify directly as telemedicine but can be used in a technologically facilitated environment. And then you'll have the same row for Medicaid, what it will cover in the state where the patient is. Remember, or I should say that healthcare is technically defined as occurring at the patient's location, not the physician's location or the other healthcare provider's location. So what's paid for and what's available at the patient's location or by the patient's payer, whether that's Medicaid or commercial, you end up with a matrix like this to see what is available through traditional healthcare reimbursement. Now, of course, when we're talking about state programs, state-funded programs or state-supported programs, there are a range of things that can be done. Reimbursement and sustainability is the second of these four components that I've laid out on this slide. And when I talk with organizations about setting up a telehealth service, I talk about the four pillars or the four components. And they include defining the service, figuring out how you're going to sustain it or reimburse it, the policies and procedures that go with it that you need to do to implement that service, and then the kind of technological platform you need to deliver it. And sustainability is only one of those. But when you're working at the state level, you can think about various ways that you can support that program, either by a direct line item in the state budget, like the Arizona Telemedicine Program has a line item in the state budget. You can think about supporting a statewide service that I think Brian Cooper is going to talk about with the statewide telepsychiatry service they have. You can talk about providing coverage in Medicaid at the state level, so then the standard healthcare services are delivered, but they're reimbursed by Medicaid. And then there are other examples like providing a statewide platform for live video, and then any provider who wants to provide telemedicine services or organization that wants to arrange for telemedicine services can then use that statewide platform. And it's a way of pitching in together and having one service or one platform available statewide instead of every program implementing its own. So there are a number of different examples of how this can be done. I'm not going to go much into detail on these components. I've left the slides in here as a reference so that you can look at them later and review. You can I talk about ways of evaluating what sorts of needs an organization has and how to find those challenges or find services to meet those needs and address the challenges that arise, about how to set up, how to evaluate the clinical flow for those services, how is that service going to be implemented. You're going to get some great examples of this in the following speakers, and so some of this will become much more apparent as you see their examples. I talk a little about best practices and how services are usually most effective when they're highly integrated into the normal flow of services, so that rather than having to move a patient outside of a regular flow to see a specialized provider over a video, that the video is integrated into the regular flow, so that when you need a specialized provider, the patient can be seen in the regular room and the regular location, using the regular support staff, and as much as possible implementing these supplemental services in the existing workflow. I have a number of slides in here on technology, but I won't go into them. It's something that the telehealth resource assistance centers can do specifically for any organization excuse me, that wants to pursue those, because there is really no one-size-fits-all in technology, other than the number one rule, which is you have to have high-quality bandwidth. But if you've got high-quality bandwidth, then there are a range of services and technological platforms that you can pursue. And it's not a simple question of which one is the best, because different strategies use different types of technology to deliver different types of services. And it really does matter what kind of service you want to provide, what sort of a form factor you need to implement it in, and what sort of flexibility you need for delivering that care. So I'm going to go ahead and bounce through the rest of these slides, focusing on the last two, excuse me, the one that drives probably the biggest principle for delivering telehealth, and that is that your clinical processes really should drive the technological design, the service design, the sustainability even, to the extent that you can make the location and the clinical processes that you're trying to support be the driver for the service that you design. So regulatory considerations are important, but they're not overly restrictive. The practical level is sustainability and reimbursement. And if you've got some flexibility there, or you can sustain services, then there are lots of organizations that are willing to develop services that will fit within a sustainability model. But planning for that is critical. Procedures should integrate usual processes as much as possible, and then the kinds of partners that you can bring into the whole process is critical as well. So I will, with that, move on. I have contact information. You can get a hold of me, and I will turn it back over to Megan and to Dr. Ratzlaff for the next part of the presentation.
Thank you so much, Dr. Neufeld. We really appreciate your presentation. I will now turn it over to Dr. Ratzlaff to talk about Washington's Mental Health Integration Program. So Dr. Ratzlaff, take it away.
Hi, so thank you so much for this invitation. I'm really excited to be able to represent the Mental Health Integration Program, and I've had the privilege of being one of the psychiatric consultants in this program, so I'll talk a bit from my perspective as a provider providing services, as well as someone that's helped support this effort in Washington State from the more administrative or program level as well. So I'm excited to share both of those perspectives as I tell a little bit about our story. So I start really with what the challenge was in Washington State around 2008, which is that we had a large program that was available to supplement for short-term disability in the state of Washington. And this is really a snapshot of the patients that were receiving that short-term disability, and that they tended to have a combination of both physical health problems, as you can see from the chronic physical conditions, as well as mental health challenges and substance use disorders. And so when the organization that was really administering this program, the Community Health Plan of Washington, looked at the needs of these patients, they felt that they really needed support for their mental health disorders as part of their overall health care. And so that really meant that we had a challenge in Washington State, because this is a statewide program, and we needed to figure out a way to have mental health services delivered throughout the state. But the majority of the psychiatrists and prescribers really live and work in King and Pierce County. So that's why there's this big red circle. So you can see it's there's a lot of population density here, but we needed a way to think about how could psychiatric services really be leveraged over this whole state. And like many states, we have lots of rural areas where there's very few psychiatric prescribers, but there were still lots of patients in need. So out of this challenge, the Mental Health Improvement Program was really born, and it was a pilot that was initiated in 2008 in King and Pierce counties, and then in 2009 was expanded to cover clinics statewide, and you can get a sense of the clinics that were covered by this map of Washington here. This is a program that was funded by the state of Washington, as well as received some augmented funding in King County from the Public Health Seattle and King County. And then it was administered by the Community Health Plan of Washington in partnership with the in partnership with the University of Washington Ames Center. So this was a really exciting program to be part of. I was fortunate enough to join this program in 2009 as one of the psychiatrists that would help deliver services across the state. And what I'm going to tell you about in our next few slides is how we thought about approaching this. Because with very limited psychiatric resources, and most of those located in one part of the state, we really needed to think creatively about how we could deliver services to meet the needs across the state. So one of the foundational approaches that we took in this for this program was to actually leverage the psychiatric consultant or those psychiatric resources in a unique way, and we really took advantage of some of the kinds of more cutting-edge kinds of ways of thinking about telepsychiatry that Dr. Neufeld introduced in the beginning when we took this approach. So we used something called the collaborative care model. This is an evidence-based approach that really takes a psychiatric consultant and helps think about how to leverage them over a population of patients that have identified mental health needs. So if you start looking in the middle of this slide, you can see that there's a team figure. And what this really says is, gosh, we're going to have to figure out a better way to deliver mental health services in primary care settings. So we're going to start with that medical provider, commonly a primary care provider, and the patient that are located out in a clinic somewhere in Washington. And we're going to add some capacity. We're going to add a behavioral health care manager. Typically this is someone who could come out on site and meet with patients. And that tended to be in our state a master's level person, often an MSW. And we're going to add some other capacities to help deliver chronic illness care management, basically. So in this case, we added a registry to track all of the patients that were identified. This is a really important part of this program that I'll talk about in a little more detail in a few more slides. But essentially this was a way for us to actually keep track of all the patients that were identified and proactively reach out to them to make sure that they got engaged in treatment. We trained people to be able to deliver evidence-based therapies, both psychotherapies like problem-solving treatment, behavioral activation, as well as medication, evidence-based psychopharmacology in the primary care setting. We used validated measures such as the PHQ-9, which is a depression rating scale. It helps both identify patients and also track their response to treatment over time. And then we use the psychiatrist in a very different way, or the psychiatric provider in a very different way. In this case, instead of them actually seeing most of those patients in person or via televideo, we actually had them providing case reviews with that care manager and using that registry and data available from the electronic health records. So they actually provide what we call indirect evaluation. So most of their time was actually spent talking to the care manager and being available on a very limited basis for direct evaluation of either the patient or to answer questions by the primary care provider. So that's what those dotted arrows in that figure represent, is that those were more as needed interactions. So using this basic model, it has been shown that you can get patients better for common mental health disorders like depression and anxiety disorders. So there's now over 80 randomized controlled trials that have shown that collaborative care is really effective and consistently more effective than usual care intervention. So I want to talk a little bit about what that looks like and some of our lessons learned in the next few slides. So the first thing is you have to, if you're going to be delivering care this way, make sure that these brief interactions and case reviews provided by the psychiatric consultant are really getting patients better. And that's where a population registry is really important. So in this case, this is a picture from one of our Excel-based registries that is actually freely available to download from the AIM Center. And what this registry shows is that you can have a list of patients. You can see these are test patients, and have a quick snapshot of what clinically how they're doing. So for example, in this example, you can see that they have an initial PHQ-9 score in the column indicated by the blue arrow. And then we can actually follow that over time. You can see there's another column right next to that that's the last available PHQ-9 score. And that allows us to quickly prioritize patients on a caseload that aren't improving or need clinical attention. And what we think that this is really helpful for is really using those scarce resources. So psychiatric time is very precious, to really focus that on the patients that aren't getting better. So this is one of those ways to really develop a stepped care model to try to increase access to mental health to as many patients as possible. On the next slide, you can see an example from an individual patient record of how this might work. So one of the things that we really focus on in collaborative care is measurement-based treatment to target. So this means that we're actively adjusting treatment until we get patients into remission. So in this particular example, this is one patient who was seen over about 3 months. She initially came in and had presented with depression, developed some anxiety as well, was really struggling with school. The work between her care manager, and this is actually one of my patients, so as myself as a psychiatric consultant, involved talking over the phone to provide case reviews over those several months. And what we really did is intensify treatment. So the patient came in. She initially wanted to have psychotherapy for her treatment. The care manager worked with her on that. The patient wasn't improving fast enough, so we added some medication intervention that was prescribed by her primary care provider based on my recommendations. The care manager really helped support that patient stay engaged in treatment. And what we saw is a nice response to treatment by that 3rd month, where the patient really now was having a score that indicated that she was in remission from her depression symptoms. And most importantly, she was able to more effectively engage in school and her life. So this is an example of how, in addition to using the telephone So I actually never saw this person. I talked over the telephone and used a shared registry to be able to help provide expert clinical advice to that primary care provider, and we were able to get this patient better. And this is a really important strategy to try to fill the gap when we have scarce psychiatric resources and lots of patients in need. So I wanted to share a few lessons learned. So that's the basic model. We work together as a team. We provide mental health care. Most of that is done via telephone psychiatric consultations. The psychiatrist is available for televideo evaluations of patients who don't seem to be getting better. Typically, in most collaborative care teams, that's less than 10% of the patients. And that really allows us to actually touch a lot of patients, even if they're not physically located next to us. However, you have to work pretty hard to have a program like this actually be effective. So this data actually shows one of the most important pieces of setting up a good collaborative care team, which is that you really need to make sure you're measuring your quality of care as you set up a program like this. So what this slide represents is a piece of this mental health improvement program that was really innovated. So in the first year, we looked at the outcomes of how well we were doing in terms of getting patients better. So you can see that with the solid blue line. And what we found when we looked at that data is that we were getting about half the patients better, which is actually pretty good for safety net settings. And traditionally, only about 20% of patients will improve from their depression symptoms. So we were doubling that, but it was taking a long time. It was taking about a year for us to get 50% of people better. And we really felt that we could do better than that. So what was put in place is that some of the payment for the collaborative care was put at risk. So each individual clinic received funds to support the hiring of the care manager and the delivering of these mental health services, and 25% of that money was put at risk. And the idea behind that was that that money would be tied to certain quality measures. And it's really important to note that when this was first implemented, that was actually what was implemented were process measures. So for example, things like making sure that patients had a complete assessment, making sure that the majority of the patients enrolled in a caseload were receiving 2 contacts per month, so that could both be in person or by phone, making sure that the psychiatric consultant was talking about the patients that weren't getting better, regular weekly conversations with the care manager. Making sure that the important clinical information was recorded in the shared registry so that the team could work together. And essentially, when all of those measures were put in place, we re-looked at how we were doing. And what we found is that we had been able to shift that time to response from about 64 weeks down to about 20 weeks. So you can imagine that that's a really big difference for patients as well as the population. We now are getting people better in about 4.5 months instead of a year. And that really makes a big difference in your ability to also serve a larger population, because as those patients get better, they move off the caseload and there's space for new patients to come in. So again, this is a really important function of setting up a population health perspective type of program. I think one of the things that is my takeaway from this is that it's really important to have accountability for your outcomes at a population level when you're doing work like this, that you really have to be looking not only at how are you doing with individual patients, but also are you getting enough of the patients better in that larger population and serving enough of that population with any program you set up like collaborative care. So what's the big takeaway in terms of impact? This program has been functioning since 2008, and there now have been over 50,000 clients served in over 150 primary care clinics across Washington. And just to give you a sense of the kind of volume in any given year, in 2016 there were over 5,000 psychiatric consultations provided, and the majority of those, 92% of those, were delivered by either telephone or other telecommunications. So this is a program that's allowed a relatively small number of psychiatric providers to have a pretty big impact on the population of Washington. I think it's important. In the next few slides I'll just talk a little bit about how I think that this is helpful and a few takeaways in terms of funding and payment. So one of the things that I think is really important to think about is that this is a solution to leverage scarce psychiatric resources. And there are two strategies that we were really targeting with this approach. The first is that we were really interested in really trying to serve a larger population, and we did this through using collaborative care management and that team structure. So this little figure on the left is to represent the idea that typically the clinics, the way that it worked for psychiatric consultation is that the psychiatrist was contracted to individual clinics. And they provided a certain number of hours of psychiatric consultation. In this particular example diagrammed in this figure, if you think about this, if a psychiatric consultant had 8 hours of contracted time, they can typically serve about 3 care managers. And each of those care managers typically has a caseload around 60 patients. So if you think about this, this is a really strategic way to use psychiatric availability. That 8 hours of time, they might be able to see a couple new patients, a couple follow-ups. But if you use it to leverage their expertise through collaborative care management, you're actually able to serve a lot more patients and be able to have them have access to that expert care. The other big strategy from this solution was the idea of leveraging the psychiatric resources that were located in one part of the state over distance. So really using the telepsychiatry. In this case, we used a lot of telephone as well as some televideo to really take that psychiatrist from their office, a bunch of us work here at the University of Washington, and get it out into the community and the primary care practices where that service was needed. I think one of the important considerations is to think about how you have to adapt this model to smaller practices, and especially the kinds of smaller practices you might see in rural settings. In this particular case, this model has been shown to be effective with an additional opportunity to leverage also that care manager time. So if you remember, the way I talked about the model is typically the care manager was located on site in the primary care practice. But for smaller solo practitioners or 1 or 2 provider practices, it might be hard to have enough population to support a whole care manager's time. So in this particular case, what I'm showing here is that you can adapt this model and also have that care manager be mostly doing her work or his work over a telephone or with televideo out to small practices. And there are several studies, and we have several examples of practical real-world implementations where this has been a really effective strategy to redefine the team, using the same principles but just really leveraging them over smaller practices. Okay. My last 2 slides, I just want to provide a little bit of information about payment, and then I'll provide some resources. So what's really exciting is that starting in 2017, collaborative care management is reimbursable by Medicare with these 3 codes, and it basically is a code that is reimbursable. A primary care clinic can actually bill and receive a monthly case rate payment. Essentially, there are several important criteria. You have to be delivering care that looks very much like the model that I described. You need a patient tracking tool or registry. You need to do regular outcome monitoring, and you need to have systematic review with a psychiatric consultant. In this case, the expectation is that a primary care clinic would contract with a psychiatric provider to provide that expert consultation, because the primary care clinics actually receive that payment. And then they would also pay for the care manager out of that payment. And what's really exciting about this is that some states, and Washington State is one of them, have also adopted, have included in this year's budget money to pay these codes for Medicaid as well. So again, that would be a state-by-state variation, but it is an exciting opportunity that this provides a mechanism for payment for some of these types of services that traditionally haven't been reimbursable. So for example, using a psychiatrist in this way typically hasn't been reimbursable until these codes came online. There's also some really exciting movement that the CMS is currently considering having these codes also be open to FQHCs and rural health clinics in 2018. That is available for public comment right now, that change. So I just wanted to highlight that, especially for those folks thinking about rural practices. Finally, I'll just conclude with that we have some resources if you're interested in learning more either about collaborative care management or how we use our telepsychiatric services in this way. I work at the University of Washington with the AIM Center, so I put our information up there. I also wanted to highlight I work with the American Psychiatric Association as part of their Support and Alignment Network, which is part of a CMS project called Transforming Clinical Practices Initiative. The American Psychiatric Association has lots of great resources around telepsychiatry, and I wanted to just take a moment to promote those, as well as the availability to have psychiatrists trained in collaborative care that's free right now as part of a grant from CMS. And so if you are in a state where this sounds like an exciting model, there's some great resources out there for you to utilize. And I guess I'll turn it back over to Megan, and we'll go from there.
Thank you, Dr. Ratzlaff. That was great. I'll now turn it over to Brian Cooper, and Brian will talk more about North Carolina's statewide telepsychiatry program. Brian?
All right. Thank you, everybody, so much for having me today. This has been an exciting program to be a part of, and it has really created an impact across our state. Next slide, please. There we go. So first, I'd like to acknowledge the funders of this program, the North Carolina General Assembly, which is our state legislature, as well as the Duke Endowment. Without their vision and generosity, this program wouldn't have been possible. Next slide, please. So I wanted to first give some background about the North Carolina Office of Rural Health. Our mission is to assist underserved communities and populations to develop innovative strategies for equal access, quality, and cost-effectiveness of healthcare for all. And we do this by working with communities to meet the health needs of all residents, seeking to eliminate health disparities, fostering state and local partnerships, providing in-depth and ongoing technical assistance, and ensuring clear and measurable accountability. Next slide, please. And here's a picture of our office as well as a list of our programs. I'm not going to read through each one, but you can see that we provide programs and offerings to all sorts of rural providers to support the safety net and to aid in access and quality of healthcare for all citizens of North Carolina. And you can see that telepsychiatry sort of fits into this network of programs that we've created. Next slide, please. So you can see with this statewide map that this is a statewide map of the HPSAs, the health professional shortage areas, as defined by HRSA, specific to mental health. And you can see that most counties in North Carolina either have a population geographic mental health HPSA or they have a facility HPSA. And you can see from this map that most counties in North Carolina don't have a sufficient number of behavioral health professionals. And this is a problem both for rural as well as urban. Next slide, please. So looking back to 2013 at the external environment, we were seeing a nationwide trend of patients presenting to emergency departments with a behavioral health crisis, and they required an assessment from a trained individual, but many ED staff just didn't have the adequate training to conduct proper assessments, and so patients ended up being boarded in the ED waiting transfer to an appropriate level of care, which often meant another facility due to the lack of inpatient psychiatric beds. In a 2008 nationwide survey of ED physicians, 79% of those physicians reported that their ED boarded behavioral health patients on a regular basis. And North Carolina was no different. Patients placed under an involuntary commitment, or IVC, were taken to emergency departments for assessment. And due to the lack of behavioral health professionals, as I covered in a previous slide, and the lack of inpatient psychiatric beds, hospitals were reporting an average length of stay for IBC patients between 48 and 72 hours. So there were several solutions that arose to help combat this, and there were two successful programs. One was initiated by the South Carolina Department of Mental Health, as well as in the eastern part of the state, the Albemarle Hospital Foundation had a successful telepsychiatry program that we utilized as our model going forward. Next slide, please. So this is a snapshot of the Albemarle Hospital Foundation project, which started in 2011 and utilized a hub and spoke model. There were 9 hospitals that were connected to one provider hub, which was a private psychiatric practice. And that was the model that we adapted for the statewide program. Below there's an image, a promotional image from the Albemarle Hospital Foundation program. And you can't see this from the picture, but that video cart actually has wheels on the bottom. And we utilize these carts to have staff put them into the patient's room and bring that equipment to wherever the patient is. And through use of the screen, the video camera, microphone, etc., patients are able to have a face-to-face interaction with the psychiatrist or whichever clinician is currently on the other line. Next slide, please. I wanted to go into the political process behind how we got this program off the ground and got, how that legislative process came to be. So there was actually a whole network of stakeholders involved with this from the very beginning in the initial proposal to the state legislature. We had the North Carolina Hospital Association. We had several large health systems involved. We had behavioral health providers involved. And so it was really a group effort with bipartisan support. And so the program was established in July 2013 under a session law. And when the funding was granted, the legislature instructed the Office of Rural Health to prepare a plan to implement the statewide program. And so we continue to engage those same stakeholders in the creation of the initial program plan, and we continue to have a quarterly advisory group that meets and provides steering and advice to the program so that we can continue to grow and improve. Next slide, please. So as mentioned, it was July 2013 that the General Assembly created the statewide initiative, and from the very beginning there were 2 partners established, the Office of Rural Health as well as the East Carolina University, ECU, Center for Telepsychiatry and E-Behavioral Health. ECU had been doing telepsychiatry since the 90s, and so we were able to utilize their extensive expertise to build up this statewide program. And that's where the Operations Center currently sits. And they've been our boots on the ground in creating out and building out this program. Funding came in the form of $2 million in recurring state appropriations and an additional one-time $1.5 million awarded by the Duke Endowment. Next slide, please. So this is the program as it stands today. There are 42 hospital sites that are currently live and an additional 15 sites that are in process to become live. There are many things that a facility has to go through in order to come online. So they're in the midst of that, and I'll talk about that in one of the coming slides. We have 7 provider hubs. Once again, the model uses a hub and spoke model. And provider hubs range from private practices to large health systems that were already in behavioral health but wanted the technical expertise of ECU to help them to build out the program to help serve their hospitals. And you can see that the green counties are rural. Most of the state is considered rural in terms of its counties, and then the gray counties are urban. So we try to serve all hospitals in the state. This is open for anyone to join, and you can see that both urban and rural take advantage of this, which is a great thing. Next slide, please. Looking at some of the challenges with the program, one of the very first things when the program was created was making sure that facilities had broadband and had access to that. So that was one of the very first things that you'd have to do. to make sure that people had the bandwidth to be able to connect. The next thing is that now we have a statewide health information exchange, but back in 2013 we did not have one. So we actually had to create a web portal health information exchange, which was a large IT project, and I'll cover some more of that in a coming slide. And some of these challenges have already been addressed in previous presentations, so I won't go too far in the weeds, but I did want to mention provider credentialing. The number one delay to having a facility come online to the program is provider credentialing, because every single provider at each hub has to be credentialed with the hospital that's being connected. And a lot of hospitals still have their bylaws in place as if a telepsychiatry provider was providing those services in person. So you're talking about, maybe a 100-page application for each clinician that's at the provider hub. So that's a very labor and administrative intensive process. And then lastly, I'll talk about the limited program scope. There are many people over the years that have had ideas of wanting to extend this program into primary care, wanting to help provide telebehavioral health in a direct-to-consumer model, or many of the exciting ways in which telehealth continues to evolve. But currently, we have to operate according to the scope of the original legislation. Next slide, please. Looking at the outcomes of the project, these are not all of the measures that we track, but I did want to show you 4 measures that we carried over from the Albemarle program. And on the left, you have the language behind that performance measure. The blue column reflects what was reported by the Albemarle Hospital program, and that was with 9 hospitals. And then on the right, we have our expected value for 2017 and then the actuals so far. And this is with 42 hospitals. So the reports of involuntary commitments admitted to hospitals, we currently have a cumulative number of 9,412, and that number is cumulative. It's not a yearly amount. The number of IVCs overturned, we're seeing about 26.1%, and that number has revolved around 30% since the start of the program. Albemarle was seeing about 28.6%, and these are only overturning unnecessary IVCs, that when the provider gets a chance to speak with the patient, that they decide that there are resources in the community that can assist them, or perhaps the patient has de-escalated, so they're able to work with the ED physician to overturn that involuntary commitment order. The number of telepsychiatry assessments conducted is now over 25,000, which is impressive. And the average length of stay in hours for behavioral health patients, originally we were seeing between 48 and 72 hours, just depending on the hospital and what behavioral health resources were in the area. And the average is still at 53.2 for this last quarter. Now that number may sound misleading, and so I've provided the median here of 29.8 hours. And the reason for this discrepancy is extreme outliers. The vast majority of patients have a length of stay that's under 30 hours, meeting that median. However, there are patients that have a level of need that they need to transfer to a facility that can fit those needs. And in some cases, patients can spend days or even weeks in the ED, which does result in skewing of that number. So as I've mentioned, there have been a cumulative number of 2,459 overturned IVCs. And so NC STEP estimates that a cumulative cost savings have been achieved of over $13 million, and that's only to state psychiatric facilities. So that does not include savings to patients and their families, savings to law enforcement, to payers, et cetera, and all of the qualitative benefits from that as well. But I did want to give you that number. Next slide, please. So Going into some lessons learned here, I have provided a checklist for you if you were to duplicate this program in your state so that you could print this out and simply check the boxes as you go. The first is to not depend too strongly on a single provider, person, or champion. We have had workforce turnover with our provider hubs as the program has gone on. There was one particular hub that was connected to the program that after years of serving us and being a terrific partner, they just decided as a group that they wanted to pursue some other projects. And so that resulted in having to have a whole recruitment program to get additional providers and fulfill that capacity again. The next is navigating the intricacies of public funding. I mentioned the web portal, which was a very large IT expense. And oftentimes when you have a large IT project, there will be delays in billing. And at the end of a state fiscal year, if you haven't been billed and that amount hasn't been paid, then state legislatures might look at that and say, oh, well, you didn't need that money. But we have to respond that yes, we did need that money. It's just that there's a process here, and so we've had to ask for carryover several times. And so you of course want to avoid that as much as possible. And with public funding, you'll have to demonstrate one of two things continuously. You'll have to either demonstrate that you can achieve self-sustainability on your own, or that you generate significant cost savings or some sort of ROI that they should continue to fund your program. The next item is developing and funding the number of psychiatric beds that your state needs. And if possible, distributing those beds across the state so that folks that are transferred to those facilities can recover as close to home as possible. And so the legislature, in response to this, has created a new bed conversion program so that rural hospitals can convert some of their inpatient beds to psychiatric beds. The next is that provider hubs that have been most successful in achieving sustainability have worked clinicians to the top of their licenses. And this has helped to reduce costs and to not exacerbate workforce shortages, because as I mentioned in the beginning of the presentation, we have a shortage of behavioral health professionals, and especially for psychiatrists. So in response to this, the state has a loan repayment program that they use to help providers that have chosen to practice in rural areas, and they have extended those benefits to include providers that provide telehealth services to those rural areas. So if a provider provides a certain percentage of their time to rural, then they can collect some of that loan repayment benefit. So that certainly helped with the workforce and the recruitment. And then finally, keep in mind all barriers that affect forms of telehealth and telemedicine. And previous presentations today have already touched on these, but be sure to keep those in mind if you were to build out a similar program. Next slide, please. So thank you so much for the invitation to speak today. And if you go to the next slide, I have a couple of websites here. The East Carolina University Center for Telepsychiatry has been, a terrific partner to have in this program, and can sort of speak from an operational perspective. They've also been doing research on telepsychiatry since the 90s, as I mentioned earlier, and so they really have a robust set of research that you can refer to if you need to. And then I've also provided the link to the North Carolina Office of Rural Health. So with that, I will turn it over to Megan.
Thank you, Brian. We appreciate that presentation. So we can now open it up for Q&A. I know we've had a couple of questions in the chat box as well. So I'll go ahead and address those questions first, and then we will bring on the operator who can unmute your lines if you have a question, and our operator, Isaac, will give more guidance on that. But let me start with a couple of questions from the chat box. These came in during Dr. Ratliff's presentation, but Brian and Dr. Neufeld, feel free to also chime in if you want. The first question we received was, what, if any, accommodations did you have to make for persons with disabilities?
Great. So that's a really important question. As I had said, this program was developed to help with patients that had qualified for short-term disability in the state of Washington. And I think the biggest thing is that those were often patients who needed additional psychosocial supports. And one of the things that I think was really helpful was actually having that behavioral health care manager role within our teams to really take and support that patient in engaging in treatment. Sometimes there were other psychosocial needs of that patient, and I think that's one of the reasons why we ended up having a lot of MSW behavioral health care managers in that role. They were able to help connect those patients to local resources to really help support them. They also did a lot of work facilitating patients getting connected to other programs that were relevant, such as the Department for Vocational Rehab, and helping support them. And we were able to help. They were able to help coordinate the psychiatric services that we were recommending with those other services that the patients needed. So, in some ways, that was really built into the design of the program. Yeah, so I think that. But I don't know if other people want to talk about how they've managed their adaptations of telehealth to address that.
Well, this is Brian. I did want to address, and this is, these are some of the questions that come up when people hear of this program. A lot of the patients that can receive services through the program may be paranoid or may be at a level of psychosis, and so there's often this question of, well, is this a service that is suitable for everyone? And Dr. Sai Saeed, who is our principal investigator of the program, he personally has not received any word of somebody refusing to have a telepsychiatry consult, or of an ED provider that has sort of gone back on deciding to give the patient a consult. So that every patient is sort of it's sort of done on a case-by-case basis based off of the patient's needs.
Yeah, and I can chime in there too from a national perspective, because there are lots of programs like this around the country. And one of the things that I think folks that are just starting to look into programs like this, it's a common question to ask, can you do this with population X? Can you do it with these patients or those patients? Can you adapt it? And what is commonly found across the country is that you've got skilled providers who are implementing these programs. They adapt their services as necessary. There's almost no population group that is just sort of right out of the gate excluded. It's a matter of looking at being careful and being cautious and being good clinicians and figuring out, okay, how can we serve this particular patient or not, and then making decisions on a case-by-case basis. Now, it is very common to have procedures in place to evaluate and how to describe processes by which we decide who's eligible and who's not, or what type of patients are we going to track into the program or not track into the program. But it is there's almost no population that is by default excluded, but there are just certain kind of common sense clinical judgment questions that need to be addressed, and you find very rarely that patients refuse care, especially because the alternative often is to just sit and wait and not see anybody in the ED, or not have collaborative care in primary care, or not see the specialist who's available by video. And there are some who will refuse, but for the most part, people just want the service. And if you can find an effective, efficient way to provide it, then it and there are obviously responsible and thoughtful clinicians providing it. There are ways to make it work very well.
Thank you. The next question, we had a question generally on, I think, Medicaid codes for reimbursement, but I did want to check, and thank you, Dr. Neufeld, for providing some resources on that. But I also wanted to just confirm, Dr. Ratzliff and Brian, did you have Medicaid reimbursement for your services?
So this is Anna Ratzliff, and essentially the Medicaid dollars did help support the mental health improvement program in the initial, continue to help support the mental health improvement program. This year, Washington State, in its current budget, has also allocated funds to reimburse collaborative care codes for Medicaid. So they are taking on, basically they've acknowledged that Medicare has established these codes and decided to reimburse them within our state. And that would be, again, a state-by-state opportunity, but for those of you in advocacy roles, I think it's a great opportunity, and I know the American Psychiatric Association is very interested in helping to support advocacy around getting Medicaid to pay for collaborative care codes because we think it's such an important opportunity to increase access to effective mental health treatment.
This is Brian. Yes, the Medicaid program was engaged from the beginning, really, after this legislation was put out in 2013. And so Medicaid has been engaged in reimbursing for these services, which has definitely been helpful from a sustainability point of view.
Okay, thank you both. Another question that we had specifically for you, Dr. Ratzliff, but I'm not sure, Dr. Neufeld, if you also have some insight. Is the mental health integration program only available in Washington State?
Great. So the mental health improvement program is a state-specific implementation of a broader concept called collaborative care or collaborative care model. And this is not the only state where that model has been implemented. It really has been implemented all across the United States and internationally. There are lots of other examples of large statewide implementations. Minnesota had a large implementation called the Diamond Project. New York State has been very active with some of their Medicaid waiver dollars in implementing collaborative care as well, as many other states have implementations of collaborative care. This really is an emerging practice that I think is very consistent with the general direction that healthcare is moving in terms of trying to think about more value-based ways of delivering services. So many of the pieces of collaborative care have not been traditionally reimbursable, and I think that has in the past maybe prohibited or limited the amount of places that have implemented collaborative care, but with the movement to more value-based, where we're really looking at can we get patients better, and that payment is more oriented around that kind of model, opens up to deliver care in these new ways where you really are using a psychiatric consultant in a novel way to leverage that psychiatric resource with those indirect consultations. So I'm very excited that actually there's lots of activity, and I would say the American Psychiatric Association and the work we're doing there is really trying to promote that. I know one other question was about psychiatrists and whether they would be interested in working this way. I'm really excited to have been part of an effort to train psychiatrists nationally, and we've trained about 1,700 psychiatrists in collaborative care over the last 2 years with support from the Transforming Clinical Practices Initiative. So we really are seeing that people all across the country are starting to think about, is this a piece to the puzzle for increasing mental health access? Again, it's complementary to things like what Brian presented. I think we really need to think all across the spectrum of behavioral health delivery. How can we use resources like technology, like telepsychiatry, to help leverage what resources we have in really efficient ways? So it was exciting to be part of a presentation where you got to see two such nice examples of that.
Yeah, I think one of the challenges, I mean, the question comes up a lot with changing any clinician's preferred mode of practicing, and it can be a challenge. I think that the UW, the University of Washington program, is a fabulous and very exciting new model not every psychiatrist is going to embrace it. And I think that what we find too is that there are, as in any field, there are early career people who are looking for a way to practice, and then there are well-established people who are doing just fine in what they're doing and won't be interested in contracting to just talk to primary care docs on the phone. But that being said, it's always a challenge to find providers that will work in a way that is, that you define as that you need. And it's always a challenge finding those providers who will deliver the service as you need it. It's when you have partners like the folks, and this perfect example, like the program at UW, who can train and show, hey, this works. We know what we're talking about. This is a great model, and it is sustainable and effective, and et cetera, et cetera. Then that's the kind of a partner. Those are the kinds of partnerships you need to move a community mental health center or a psychiatric group that works with primary care in your community or in your state or whatever, that can bring that level of authority and experience and say, yes, this is how it works and this is how it can be done. And that's how we end up gradually moving practice to more efficient models. And it's always going to be a mix of direct. Go ahead.
Oh, I was going to say along those lines, we got a question about the collaborative care model, specifically what's attractive to psychiatrists, that they want to be involved in this model. And I think that goes along with sort of what you're saying, Dr. Neufeld. So how were you able to attract the psychiatrists, Dr. Ratzlaff?
Yes. So I would agree with what everyone is saying. I'll say, speaking as a psychiatrist, it's really been exciting and fun to practice in a different way. But I think there is a temperament. I mean, not all psychiatrists will feel comfortable with indirect assessments. What we tend to see in the psychiatrists that have been really excited in engaging around this work is that it does tend to be sometimes people who are more early career, people who are really population health minded. I think we have a lot of providers who are really seeing that they want to have a broader impact than a limited number of patients they might be able to see in person. And most of collaborative care is something that's done complementary to continuing to deliver specialty care services. So most of the folks who work in collaborative care as a consulting psychiatrist are usually people who are doing this a day or two a week in complement to maybe a direct specialty care practice where they're seeing patients directly. And I think people like the idea of having some different ways to help serve their communities and really be able to leverage their expertise in some ways, work as part of a team. I'll just say personally it's really fun to work with the care managers and the primary care providers. When you have, I developed longitudinal relationships with the folks that I worked with, and it really, you become part of this primary care team in a really exciting and honestly fun way to deliver care. Plus, you get to see patients get better. And one of the really exciting things about collaborative care is if you're doing it effectively, you're getting feedback on both how your individual patients are doing as well as the impact you're having over a population. And both of those are really powerful motivators. I do think that collaborative care is now really, as part of the American Psychiatric Association, which is our national professional organization, it's really become part of the conversation of one of the ways that you can deliver care. And I think that does make it much more exciting and attractive to psychiatrists who might be doing this work. So if you have people in your community that might be interested, there are lots of great resources now that are freely available to help get training in this area. So I think that's really exciting.
Thank you. And then we have a question for you, Brian, about your program. Is it only available in the ER, and were the hubs available 24/7?
All right, great question. So yes, under the current program scope as defined by the legislation, it is only existing for emergency departments. And in terms of provider hubs, it really depends on the hub and what the practice or health system wants to invest and what they see as sustainable. So it really depends on the hubs. I would say that most of them only practice the service from office hours 8 to 5, whereas some of the others, but a minority of them, do provide the service 24/7.
Thanks, Brian. So at this point, we have covered all the questions in the chat box. Operator, are you there? Do you want to open up the phone lines if there are any questions from the audience on the
Absolutely.
phone?
If you'd like to ask a question over the phone, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question. We'll pause for just a moment to allow everyone an opportunity. And once again, to ask a question over the phone, that is *1 on your telephone keypad. And it appears there's no questions over the phone at this time.
Okay, I have a couple of questions that we received before the webinar during registration, so I'm going to ask these now also for our speakers. Please address services in light of HIPAA regulations. What are the best HIPAA-compliant software to use for doing telepsych? Do you have any recommendations, speakers?
I'll take that one. And I kind of mentioned this a little in my presentation. There is just such a wide variety. There is not a best platform. You really need to work with your local TRC or a local partner that has some experience to walk you through the various things that you need, features that you need or don't need. It's easy to just write a big check and buy the top of the line and end up with 2 or 3 times what you need. On the other hand, there are it's really decreasing. There aren't very many programs anymore that are not going to be very well encrypted and meet all of the requirements that you need for HIPAA. But I also want to underscore that HIPAA compliance is not a feature that can be built in. It's a process of how you use the tools that you have. You can't just say, hey, I bought the right stuff, so I am HIPAA compliant. It's about how information is transmitted and how it's stored, and so you really have to have those processes in place and be working with a company and partners who understand those processes and can help you verify that you are in fact following those processes and that the data that you're using and transmitting is stored in compliance with those processes all the way through.
Thanks, Dr. Neufeld. And one other question similarly. Any tips for choosing vendors and implementation checklists, i.e. workflows, IT?
Oh, wow. The TRCs, all of us, get questions like this so often, and it really, I mean, if I could answer it in 2 sentences, then you wouldn't need the TRCs. It's just a very complicated question, and so I'm just going to, again, underscore, find some experienced partners. If you're in a healthcare system that has an IT department, or if you have a trusted vendor that you work with, great. If you want to get more than one perspective, then you can pursue multiple perspectives various ways, but certainly the telehealth resource centers are federally funded to provide this kind of information and walk people through these kinds of questions.
This is Brian.
Go ahead, Brian. Go ahead.
Oh, sorry. If I could actually just echo that, our telehealth resource center, the Mid-Atlantic Telehealth Resource Center, has been instrumental in providing advice to me over the years, and I think that it's a terrific program. So I definitely encourage you to reach out if you're thinking about those.
And this is Anna Ratzliff. I'll just add, if you're specifically, wondering about collaborative care, I think there are some important considerations around IT, especially around the registry function. The AIM Center has some nice information around sort of the core functionality that you might need. I'll just put out, I think, kind of a general warning, somewhat like my other two colleagues, that the one thing I would caution against is quickly jumping to try to build a whole registry capacity within your EHR without some pretty good experience. We've seen some practices sort of go down that road and not end up with what they hoped for at the end. So I encourage you to check out the resources around registry functionality on the AIM Center website. Specifically, I mean, it's a tiny piece of the IT, but again, a kind of similar thing, that there isn't one right answer for any organization. So thinking carefully through choices before jumping down to paying for something really expensive is the one word of caution I would give. And hand it back to you.
That's great. Thank you all for that. Great advice. So at this point, we will close the Q&A portion of our webinar. I'd like to thank all of our speakers again for great presentations and a wonderful discussion, and thank you all as our audience for all of your questions. I'm going to go ahead to our next slide, which actually shows a list of resources, and as we mentioned, these will all be shared with you after the webinar in the next couple of days. We'll also be posting the slides and the recording online in the next week or so. So you'll have these resources, because unfortunately you can't download them or click on them right now, but they'll all be available for you in the next few days. So a couple of resources that we wanted to share, and I know our speakers have also given you a number of resources as well. So to close out, I want to thank everyone again for joining us. Thank you to our speakers again. Please use the contact information provided on this final slide if you have any additional questions for us or the speakers, and we'll ensure that our speakers receive any questions you might have. Finally, thank you for joining us. As I mentioned, you'll be immediately directed to an evaluation at the conclusion of the webinar. Please take a few minutes to complete the survey. It provides us with useful information for our future projects, so we really appreciate your feedback. And again, thank you to our speakers for their great presentations today. We really appreciate it. We'd also like to thank our funders, HRSA, for their support of this webinar. So in conclusion, thank you all for joining us, and enjoy the rest of your day.
And this concludes today's call. Thank you for your participation. You may now disconnect.